Good afternoon, everybody. Thank you for coming to our session. We're going to have fun. So we're first going to, oh, hang on, I've got to get my thing. All right, so first we're going to, this is Dr. Hiroshi Ninami, and I'm Dr. Teresa Kieser. Hiroshi is from Tokyo. I'm from Canada. So the first speaker will be Dr. Chase Brown, and it's entitled Skeletonized Beta Harvest via Sternotomy. Chase, Dr. Chase.
Okay.
Papers.
Thank you. It's a privilege to be here in London with everybody. Hope everybody enjoyed their lunch, and it's great to get back into the session. So I'm going to talk about skeletonization of the bilateral internal thoracic arteries. The key concepts for this is we need an approach that is atraumatic. We have to prevent spasm, something that's economical, that is not terribly time-consuming, and something that's easy and that we can reproduce and teach our residents and fellows. I think another key concept is how far proximal and distal you want to go. I try to take the first intercostal and then also in just before the bifurcation to not decrease sternal wound healing. So we talked about it this morning, a little bit about product envy in cardiac surgery. And if you think of the devices that we use to take down skeletonization of a beta, we have a retractor, we have a Bovie, which was developed in the 1920s, clips, and something that I have been using more and more is the harmonic device. And the reason I think the harmonic device is good is because it provides some of the things that we can do for what we talked about, these key concepts. It's age-traumatic, it's economical, and I want to show you some video of how we use this. So what is the harmonic synergy blade? This is a device that the tip will actually vibrate at 50,000 hertz, and this actually denatures proteins. It actually doesn't cause coagulation, so it actually seals the vessel, and you put gentle pressure on branches for about 3 seconds, and this will actually cause sealing and not anticoagulation. It's very atraumatic, it prevents spasm, and significantly less thermal spread. So we're going to start with sternotomy. One of the most important things is to make sure that you're midline. This is what we stress with our residents and our fellows, especially when taking bilateral internal mammary arteries. We're going to achieve hemostasis, and if I can, I try to do it extrapleurally. I think this is a good approach where it's less traumatic, it keeps the lungs away, and you still get the visualization that you need. So here we're going to start with the Bovie. You can do this with scissors, or you can use the Bovie, but you got to first excise the fascia over the internal mammary artery. We're going to sweep that vein away, and then once we have the fascia down, we can then use the harmonic, and we're going to use this at an energy level of 3, and this vibrating tip will actually seal the vessel by denaturing the proteins. And the way that you use this is you just slowly move it around, and the fascia actually dissolves and actually gets vaporized. And this is a great technique for taking down your intercostals that are about 2 millimeters or less. And you can see here when you pull down pressure and it's not coming down, that indicates that there's a branch there. So we're going to just put gentle pressure on that intercostal, and we're going to seal that vessel. You want to try to get circumferential control around the internal mammary. And we're going to work proximally and distally to proximal, and the goal is to get a broad front and to really open up the space. And occasionally you may avulse a branch, and this happens early on because you don't actually know how long you need to put pressure on that branch. When you do avulse a branch and there's bleeding, then you have to clip. And if you leave yourself a 1 millimeter, 2 millimeter nub on the branch that you're trying to seal, it's always safe. So if it does avulse and there is bleeding, you still have a little intercostal nub of the artery to go back and clip. And as you work up to those larger intercostal branches, when you start out using this device, I would always still clip them. But as you gain more and more experience, you can actually have the confidence to take down these larger 2 millimeter intercostals. But occasionally, if I see the branch looks very big, especially if it's over 2 millimeters, then we'll go ahead and clip it and then divide it. We want to work all the way up to where that first intercostal branch is. And when you get to the thicker fascia at the top, sometimes the harmonic works, but I find it to be more economical to switch back and forth. I think people who have a lot of experience can do the entire thing with harmonic, but I still feel like the thicker fascia, it's easier to go back to the Bovie. And then if you remain extrapleural, you need to make a trough for your internal thoracic artery. So here we're developing the space. We're going to stay right on the pleura, and we're going to go all the way down deep to where the phrenic is. Now, we're not going to try to see the phrenic, and when you do get deeper, we'll do some blunt dissection as not to injure the phrenic. But once you have that trough made, it's going to make a very, very nice lie for your internal thoracic on the left. Now we'll switch over to the right internal thoracic artery, and the concepts are very similar. We're going to start by taking the fascia down. Again, I start by using the bovie. I just find it to be easy and straightforward. And then we're going to start to identify where those branches are. We're going to use the energy on 3, and we're going to just continue to develop space. So staying directly on the mammary. And the nice thing with this device is that you can actually touch the mammary with it for almost a second without causing any injury. So when teaching residents, it's actually, I think, it's easier to teach than causing thermal damage when a resident causes that hematoma from thermal spread. What occasionally happens, though, you'll hit the vein, and this is not going to cause coagulation. So if you do get bleeding, you have to identify that. If you see it on the vein, you'll clip it. Occasionally, you'll see bleeding on the chest wall, and you'll be tempted to try to stop it with the harmonic, but it won't work. You need to switch back to cautery to stop those chest wall bleedings because it's not designed to actually coagulate. But it is great for sealing these vessels, and it does it by staying directly on the mammary without developing that spasm that you occasionally see when you get close with cautery. I think this does have a little bit of a learning curve, and there's been great research on this, and Dr. Kieser, who's done a lot of the research on this, is on our panel, so I'm hoping that she can comment on this device. And as we continue to move more proximally, we develop that fascial plane again with the bovie, and then we can switch back, and then you'll start to locate those large second and third intercostal branches, and with just gentle pressure, you can see the branch sealing. And it takes up, this video is sped up about 50%, but you generally need between 2 to 3 seconds of gentle forward pressure, and you'll just slowly see it seal. And then we'll continue to move more and more proximally. I think when you do it extrapleurally, you can stick your hand in there and push the pleura down a little bit. It really puts a little bit of tension and allows you to develop that space. And we're going to work all the way proximally until we see the internal thoracic vein. And again, you can do this all with the harmonic scalpel. As you get more and more confident, it becomes easy, but I always rely on the cautery when I get into trouble. So if I'm having a hard time dissecting something, it's easy to just fall back on that because it's something that we have all used so often. So here you can see we're just skeletonizing quickly that internal thoracic vein. And in general, we'll try to leave these as be atraumatic as possible. But if you're worried about having length of your internal thoracic artery, we can clip these, or clip the vein, to give you a little bit extra distance. And here you can see we're going to put 2 clips proximally, we're going to put 2 clips distally on that large mammary vein, and we're going to divide it so it can fall down in the trough that we want to create, because this is a graft that's going to be extended with a radial to a PDA. And then after you divide that, you have maybe 1 or 2 more branches to try to ligate. And here you can see we're just developing the trough for the right internal thoracic artery. And then if we're all the way up to the subclavian vein, and we take that last intercostal branch, then I'm happy with the length and the dissection is complete. At that point, we'll turn our attention to giving heparin, and then we'll divide the leda and the reta on both sides. So skeletonized beta with the harmonic synergy is a great tool to use. It's atraumatic, it's economical, it's teachable. Unfortunately, this device does not have a full production. It's actually was discontinued. It's coming back for a limited production, but I think this is a call for all of us that we need novel techniques, we need innovative technology, and we have to work with our industry to provide different options for this. Because as we know, the bovie was created 100 years ago. We're still using technology that's 100 years old for many things in our specialty. So thank you.
Thank you very much, Dr. Brown. That was a clear and precise Yeah, you can sit here. Yeah, sit here. Exposure of the skeletonization of the IMA that we all love to do because of the harmonic, and it is coming back. It'll take a little while, but we're all hopeful that it will be for everybody who wants to use it, because I'm in harmonic scalpel withdrawal myself. Okay, so are there any questions? Yes, Dr. Lally.
Yeah, hi. I'm Dr. Lally from Paris Cardiac Surgeon. We did use this harmonic, but we had some bleeding in ICU. There was some collateral that started bleeding, and after some bleeding, we decided to put apart. Do you have this experience with your?
Yeah, so a couple of things that I've noticed is when you take the harmonic down, you can occasionally find little like nubs of intercostals that have been sealed. And oftentimes if I see them while I'm preparing it, I'll often clip the larger branches. Of all of my cases, I've not had any takebacks for bleeding. I think it's actually an excellent device. If you seal things properly, you don't have to worry about a clip coming off. And I know in your series that you've published
That's right.
on hundreds of patients, takebacks was minimal.
Okay, thank you.
Okay, maybe we should move on to the next one.
I mean, I can't see it.
Oh, sorry. Sure. Oh, there we go. Okay. We have one agenda for the two of us.
So the next one is the Dr. Davier Wara. Thank you. Oh, thank you.
Oh, yes, Perose. Hey, welcome, Perose.
Good afternoon. First of all, I'd like to thank the organizing committee, Dr. Pascas, Dr. Taggart, and Gianluca for the kind invitation to present. I'll be talking on how to harvest a beta through a left anterior small thoracotomy with the help of a patient that I operated about 3 weeks back. He was a 58-year-old male who presented with NSTEMI, otherwise very healthy, no other comorbidities. Apart from that, he was a known smoker and actively smoking about a pack a day. He had preserved biventricular function and dimensions, and he had no relevant valve pathology on transthoracic echocardiogram. This was his angiogram. The right coronary artery had several irregularities, but nothing significant. And here you see in the middle, the LAD has a significant lesion, an ugly lesion actually, in its proximal segment. And on the right, you see the circumflex artery, which bifurcates into two OMs, and both these OMs have disease proximally. So we decided to operate this patient through a left anterior small thoracotomy. We give a 30-degree right lateral position and make a about 6 to 7 centimeter incision. I put a finger inside to feel the apex of the heart to see where exactly I am in relation to the apex and the lateral wall. Then we place the retractor, which elevates the upper part of the thorax, which facilitates the takedown of the internal mammary artery. So we hook this up to a pulley, and the pulley helps in elevating the upper part of the thorax. It's extremely important, as I'm looking inside, to see that the blade of the retractor does not compress the left internal mammary artery when you're doing this. So the blade should be more lateral. I usually, as has been already discussed in the previous presentation, also prefer to take the mammary skeletonized. Unfortunately, we still don't have the harmonic scalpel for MIS, although we are hoping to get it next year. So we still use the cautery and clip, and cut technique. If there is enough distance of the branch that can be dissected off, then we can also burn one end of the branch. So I'll just run along. So here you can see that we use the clip, and cut technique. I'll keep moving on. So here you see the subclavian vein at the upper end. So you can go all the way, even beyond the subclavian vein if you like. And distally, again, you can reach all the way to the bifurcation without any issues. The reason being that your incision is more lateral than a routine mid-cab incision, so the visualization of the entire left mammary artery is much easier. So here the distal vessel is clipped off, and place a bulldog, it's cut. And what we do is we place this mammary artery in what we call as the jacuzzi. We take a 3 cc syringe, put some papaverine into it and warm saline, and put the mammary into it. So that's the jacuzzi. So once the left internal thoracic artery is taken down, then we move towards the right. So we start dissecting the mediastinal fat. It's important, as you can see, to remain flush with the sternum, because you don't want tissue hanging from the sternum, because it will obstruct your vision of the right mammary artery. Now, this patient, more importantly, had a mild pectus excavatum, which makes takedown of the right mammary a bit more difficult, because the mammary disappears behind the sternum. So in such situations, what I do is I take down the vein as well along with the mammary, because you can tuck down on the vein and the mammary comes into view, as you will see. So I place about 2 to 3 stitches as far right as possible into the pericardial fat, and these stitches are then pulled out from the lateral chest wall on the left side, and this sort of depresses the mediastinum and the heart, and increases the space in the anterior mediastinum. The next step I also use is the octopus nouveau. So it comes subxiphoid. You can see this is just the dilator, which will be followed by the rod for the stabilizer. The pods clip onto the rod, and here you can see that you can use the octopus as a retractor for the lung, and this helps. You can see the mammary artery pulsating here, but you cannot directly see the mammary artery. So, and you can see that the vein is huge. So in such situations, I usually take down the vein as well, and behind the vein, then you can very well localize the mammary artery. So here you see, as you go along you can take the entire length of the mammary artery. Of course, if you have had a harmonic scalpel, it would make life much easier. But because we have the cautery, we have to use the clipping and cutting technique. As you move downwards towards the distal end, you can use what you see, these angled forceps. These angled forceps also facilitate better visualization of the distal portion of the mammary. So I'll just keep moving. So here we've almost reached sort of 3/4 of the mammary. Since we have to only graft the OMs, you do not need the entire length of the right mammary artery. So the mammary is then clipped off. That's the mammary, and this is the vein. And it's cut. And then we move to the proximal end. I usually use 3 to 4 clips at the proximal end. You do not you do not want that proximal end to slip off. Because you'll end up with a sternotomy, and you all know that even in a sternotomy, if the mammary slips off, it's a nightmare to get hold of it. So once the right mammary is harvested, we open the pericardium at first only over the right ventricular outflow tract, because that's the point where I want to do my Y anastomosis. And so I use, again, the blade of the octopus to stabilize the left internal mammary artery. And so that, because this anastomosis, it looks very clear here, but it's within the thorax. It's not outside. So you do not want the mammary to be dangling around while you're doing this anastomosis, and this being the most important one. So we usually start at the far end. So that's actually the toe of the, will be the toe of the anastomosis. And once you finish the toe, you parachute the right mammary down, flip it around so that you can visualize the entire border or the edge of the right mammary. And following that, you continue onto your side of the anastomosis. Initial stitches, avoid taking them direct because the angle with which you take it through the right and the left mammary is different. So you don't want to try and yank it. But as you move towards the heel, you can take direct shots through both at one time. And that's the anastomosis, which is then completed. And then I fix the Y anastomosis to the pulmonary artery on the lateral side. Then the first anastomosis to be done is the LAD, which is first stabilized, it's opened. For the LAD, for sure, I use a shunt in every case. And I start again on my side of the anastomosis, finish the heel, and move on to the opposite side. So I'll just run down. The LED is similar to a mid-cap, so there's nothing special about it. So once you reach the opposite side, you finish the toe and come onto your side, and the LED is done. We always use a flowmetry assessment of the graft. Then I open the pericardium towards the right, and also I place clips and open it around the apex towards the phrenic nerves. So this frees up the heart a lot, and then using a peanut, you can push the heart and place just the head of the starfish. This was for the first time described by Kita. I think he's in the audience here. And it really facilitates better positioning of the heart. I usually use this ligature, and then I pull it out through the chest wall. And here you see how well you can see both the obtuse marginal branches. So we then start with the sequential anastomosis for the first marginal. So I usually use, you see this white thing, I usually use this shunt. It is actually a silastic loop that we use actually to occlude vessels. I cut it and I use it as a shunt because it's got a lumen and it's totally atraumatic. Even if you stitch through it, you can easily break it off without affecting the suture. So as long as the size of the coronary is, about 1.75 to 2, you can easily use this as a shunt. So once the heel is done, we always do the heel first in this case because that's again the farthest away from you. So the basic idea in minimally invasive CABG is to do the far end of the anastomosis first and then come towards you. Never go away from you, because that makes visualization of the anastomosis extremely difficult. So once the sequential is done, we again move on to the next obtuse marginal. This was a sort of an easier case because both the marginals, I didn't need to reposition the starfish at all, just the stabilizer. And so here you can very well see the second sort of end branch of that circumflex. Here you see that shunt going in. It's totally, again, as I mentioned, atraumatic. And again, you see that I start at the heel and go outside in on the vessel. It makes life much easier if you sew it in this fashion. Of course, if you have a calcified vessel, you have to innovate at the spot. You cannot go outside in on the coronary, but as long as the coronary does not have calcification, you can go outside in on the coronary. So you complete the entire heel, parachute the mammary down, and then you can take these in. This becomes very easy afterwards. You can take it in one bite, both the coronary and the mammary, and that's completed anastomosis. The shunt is then pulled out. One thing you have to remember when you use these shunts, either you put a small ATO on it, but please do not forget to remove it at the end of the anastomosis. And so we do the flowmetry again. And yeah, this was just to show that finally I had put clips here. This is just for my orientation when I want to close the pericardium. You can see the two clips here. I can close the pericardium very well at the end of surgery. If you don't put the clips, it's very difficult to identify what part of the pericardium was attached to on the opposite side. So that's the final graft. The Y anastomosis here. This is the Lima LAD, and the Y going down from the pulmonary artery along the left atrial appendage to the lateral wall. With that, I'd like to thank you for your attention.
Okay, so I think in the interest of time, we're going to move to the next talk. And thank you, Dr. Deviwala. That was a beautiful depiction of a very complex procedure, but you made it look not too bad, actually. So we're going to move on now to Dr. Richard Vitale, a traumatic endoscopic right radial artery and saphenous vein harvest, please. Dr. Vitale.
Well, good afternoon, London. Hope you're all having a great time in the conference as well as the city. A tremendous amount of history. I'd like to take this opportunity to thank the board for affording me this opportunity to talk about a procedure in which I'm extremely passionate about. I've been doing for a number of years, and shortly you'll see exactly how many years that actually is. So as they say, love what you do and you won't work a day in your life, and that's truly my experience with cardiac surgery and specifically endoscopic vessel harvesting. So as an outline for my talk today, I'll attempt to define what minimal touch means to me, my journey towards that, why we should be doing this, how I do it, and some of my colleagues, and a few conclusions. And hopefully, if I do my job well, there'll be two takeaways that hopefully you'll bring back to your centers and apply to your practice. So definition of atraumatic minimal touch, EVH, is a surgical technique which minimizes tissue trauma while preserving the perivascular tissue, all with the outcome of decreasing vein graft failure. So my journey began in 1996. This was what I was doing, fortunately for only 3 months. My back certainly appreciates it. A number of months after this, we started with EVH, and for quite a few years, everything was going well until we decided to expand and start doing endoscopic radial. As you might be able to see there, there's not a tourniquet on that arm. So we had to figure out how to perform this procedure while the arm was being perfused with the technology that was available in the late 90s. After a couple of challenges, we realized that we had to decrease the amount of dissection we were doing while harvesting the conduit, and that made all the difference. So after that, not realizing it, we did start our minimal touch technique in endoscopic radial, and then quick after that, applied that to our vein. And certainly the conduit quality increased dramatically. Now the why part, just going over a few small studies, just demonstrating some very important key points in minimal touch technique, is the preservation of the perivascular tissue, which in these studies by Angelini and Dashwood show that it can decrease the intimal hyperplasia by maintaining the local concentration of nitric oxide. Now, the biological cascade of neointimal hyperplasia is significant, and it starts basically while we are harvesting the conduit, definitely on the back table, and certainly while they're in the ICU, and continues weeks and months thereafter, changing the entire composure of that conduit. This is a nice little depiction by Sistina showing the start of the minimal touch technique and with the end outcome of reduced graft failure, and showing all the different components as to why we are doing this and why it's so important to continue its evolution. So the OCT studies that have been done in '07 and thereafter, as we saw yesterday in our e-poster sessions, are making a resurgence. And it's not, shouldn't be an issue as to why it is, because it's a wonderful pictorial of seeing what's exactly inside of our conduits, our veins and radials, what they look like. So for those of you that are not familiar with OCT, it's basically an optical ultrasound. It's a catheter that's inserted into the conduit, and it's pulled back, and we take section pictures. And you can see wonderful structural components of the intima and media as evidenced here. So it's something that I always look at because a picture tells you 1,000 words, and some of these studies are very enlightening. So here's one of the studies by Dr. Poston, and I was fortunate enough to participate in some of these studies with him and the University of Maryland. So one of the areas that are an opportunity for improvement are the branch points. So there's multiple studies now showing that there is a damage that's occurring within 3 millimeters of that branch point. And most of the time it's occurring after dissection and or excessive countertraction. So in conclusion of Dr. Poston's data, the conduit quality is altered by intimal injury for various reasons, pathology, and intraoperative spasm. So here's a wonderful picture of OCT of a vein, and here's the blunt dissection damage that can occur after that, and branch point damage. And again, this is something that I think about every day when I approach a patient, that this is the #1 area of major damage to an endoscopic vein or radial. So here's Dr. Lundy's data, which is very impactful, 26 patients, single center, looking at OCT. And again, if you look at the bottom, the most common area of injury in 81% of the cases is in the vicinity of the side branch. So now we have 2 studies showing the exact same outcome and opportunities for our improvement. So again, just to reiterate, and you can see why I'm doing this, at the bottom, 81%. So this is a number that I walk into the operating room thinking about, and certainly all my colleagues as well. So a number of years ago, looking at this still, we would be very excited and say, wow, what a wonderful job we're doing. Looks like it's not bleeding, looks like a nice conduit. But over the years, we have learned through data and trial and error that retaining the perivascular tissue is extremely important. And you can see on this photo, it's not on the vein, but in the periphery. So that is something, as we see, we slowly begin to work towards keeping more tissue onto the conduit. So as you can see here, in a picture by Matthew Petrides, this is where we want to be when we're dissecting. We want to see the vein, but we also want to be dissecting away with it. So the shear force from the conical tip is not disrupting the conduit. And here's a wonderful depiction of this patient is definitely within the 81% club, because that tributary here is extremely stretched with the countertraction. You see the forces that are being applied, and here's the hemopro, which is going to be dividing. So this is one area of excessive countertraction from providing issues. And here's where, again, where we want to be when we're dissecting, either the vein or the radial. We want to dissect down here away from it, and we want to keep the perivascular tissue attached. So here's a number of small videos depicting various aspects. This is endoradial. Again, this is the beginning of the tunnelplasty. So we started with a regular 3-centimeter incision, Army, Navy, dissecting up the fascia as far as we can see, and then inserting our hemopro to make the cuts. Sorry. So we're continuing the tunnelplasty all the way up. Again, there's no tourniquet on this arm. This arm and radial is being perfused as we go along. And now we're up in the antecubital fossa, which is the end of our dissection, verifying the end of the dissection. Then we come back, and now we're just making 2 cuts alongside the radial all the way up. It's basically 3 straight lines. We're doing our tunnelplasty and then cutting on the either side of the vein all the way up. And you can see what great visualization. We see exactly the location of the radial and the veins on either side. And then if necessary, we can do very localized dissection with the device, making sure we can see everything that we're cutting. And now so then once we're finished with that, with the normal stab and grab, we pull the radial out, divide it, and move on. So now we're transitioning over to the vein, doing an anterior minimal dissection approach. You can see the vein is about 6 o'clock, and there's a significant layer of tissue between your conical dissector and the vein. The next phase is the posterior dissection, again, staying away from the vein, having a nice amount of tissue in between, retaining your perivascular tissue. Then after that, if necessary, we do a tunnelplasty in the leg, opening up our working space so we can identify the vein itself. You see it's about at 6, 7 o'clock there. Then we move on to dissecting and dividing tissue. So whatever tissues alongside of the radial or vein is being divided. If necessary, we can do some focal dissection. And then we continue this up. You can see the adipose tissue. You can see the vein encased in a significant amount of perivascular tissue. And we just continue cutting all the way up. And this is a nice depiction of, again, of the 81% rule. There's a branch coming up right here, and now we're just dividing it within the periphery. There's no shear forces applied to it, and that's a very happy conduit. So this is some of the outcomes that we have. You know, we can take a conduit as long as possible with the radial all the way up to the antecubital fossa. We always look posteriorly and make sure there's not any anatomic variation, and then taking out these conduits with significant perivascular tissue attached. So in conclusion, the minimal touch EVH is safe and effective. The preservation of the perivascular tissue may assist in decreasing vein graft failure. Please do not be part of the 81% club. When you go back, communicate with your teams that this is one significant improvement. If we can stay away from manipulating the vein branches, we will elevate the quality of our conduits, as well as the counter traction. There definitely needs to be advanced training and education opportunities necessary to propel this technique. And in 2025, we will be working on some of those education and training modules, but we do need your help and support. So if you're interested in minimal touch, if you're doing EVH, if you're doing open vein radial, please contact us at endoscopicradial@gmail.com or minimalT, which is minimaltouchvessel@gmail.com. And if you're really interested for more exciting stuff, tomorrow at 1:30, thank you, we have the Endoscopic Vessel Symposium upstairs, 1:30 to 5 o'clock. A number of local experts, as well as from the United States, presenting a very significant impact on their advances on minimal touch technique. Thank you.
Thank you. Thank you very much, Dr. Vitale, for this comprehensive and clear, beautiful movies overview of this important topic. Thank you.
So next speaker is Dr. Timaru Niazi. He's going to talk about the coronary endarterectomy. 900 cases.
Thank you. Good afternoon, dear colleagues. I feel honored to be here for this presentation. Due to some last-minute scheduling issue, Dr. Fang did not make it here, and so I'm stepping in to present on his behalf. Today, what I'm sharing is the surgical outcomes of coronary endarterectomy, a single-center experience. I have nothing to disclose. Let's see some background information first. With the aging and widespread use of PCI techniques, we are facing more and more diffuse coronary artery disease patients, including the primary long segment stenosis or occlusion, with or without stenosis of major branches, or severe long segment calcification of coronary arteries, and also the long segment in-stent stenosis or occlusion of the coronary stents, which is also named full metal jacket. This figure shows the use of coronary endarterectomy technique at our center, which indirectly reflects the increasing trend of DCAD patients. Clinical guidelines emphasize the importance of complete coronary revascularization. However, in DCAD patients, revascularization cannot be achieved by conventional PCI or CABG techniques. So, coronary endarterectomy in combination with CABG can be the last option for complete revascularization in patients with diffuse coronary artery lesions. Unfortunately, early studies showed high incidence of perioperative myocardial infarction and mortality after coronary endarterectomy. And the follow-up outcomes are also controversial. So, the question is, should we give up on these patients or perform endarterectomy? On reviewing literatures, we can find that the prognosis of DCAD patients is very poor in the absence of coronary revascularization. From here, we can see that the 5-year mortality rate for untreated diffuse lesions can be up to more than 60%. Here's a report from the SDS database. This analysis included more than 30,000 coronary endarterectomy patients. The overall use of coronary endarterectomy is up to 2.9% among all of the patients receiving CABG. The results show that 30-day mortality was 3.2%, and these patients shared higher mortality within first year and rehospitalization for myocardial infarction within 3 years when compared to isolated CABG. And these results were similar afterwards. So, although with higher risk than isolated CABG, CE with CABG technique might potentially be better for DCAD patients. We summarized our single-center experience. From September 2008 to January 2024, a total of 902 patients underwent CE with CABG procedure, including nearly 1,000 coronary targets. And let's get back to this chart showing the increasing trend of coronary endarterectomy at our center. And last year, we can see from here, the proportion of coronary endarterectomy reached around 5% among all of the CABG patients. Here are some surgical details. It's worth mentioning that operative details were not well recorded for the early years. So what I'm showing here is our techniques of recent years. The full-length open technique was preferred on left anterior descending territory in order to completely remove the atheroma from the diagonal branch and the septal perforators. To avoid the competitive flaw, we sometimes cut off the proximal part of the plaque, or in very rare cases, just suture the proximal coronary artery. Decision on the range of the CE and the management of distal part was based on the vascular condition. The endothelial tissue distal to the endarterectomized part is stabilized with 8O proline suture. Oh, sorry. We just cut off the distal part of the plaque near to the normal endothelium and just stabilize it with 8-0 proline. And sometimes a gauze ball was used to clear the tissue debris, especially in patients undergoing the removal of the coronary stents. And Lima-only patch technique is advocated where possible, since it might potentially populate the endothelium of the endarterectomized left anterior descending and promote better long-term patency outcomes, although this lacks specific evidence. The major branch is also constructed where possible. For example, in this case, the coronary plaque was removed completely from the diagonal branch and the left anterior descending. Then a vein patch was used to reconstruct the diagonal branch, followed by a Lima-only patch technique to the left anterior descending. Open technique with the vein patch was also used for left and posterior descending artery. The other technique is closed endarterectomy, which was preferred on the territories other than left anterior descending. This video shows the incision of RCA trunk near to the bifurcation. A small incision was made and the plaque was just dragged out. According to our experience, partial removal of the restenosed stent is also can be safely performed on the left anterior descending artery. And it's worth mentioning that an open technique might be better to remove the stent. Let's look at the patient characteristics. The mean age was 61 years, and most of the patients were male. The mean EF is slightly reduced, and some of the patients underwent concomitant other procedures. CE was performed mainly on left anterior descending and right coronary artery. The incidence of postoperative myocardial infarction was 6.1%, which is very similar to the result of SDS database analysis. During a median follow-up of 13 months, 35 patients died, and 118 of them suffered from MACE. The overall survival rate at the 1 and 3 year were more than 95%, and MACE-free survivals at 1 and 3 year were 91.1% and 82.8%, respectively. No difference was observed regarding the overall and MACE-free survival between on-pump and off-pump procedure. We also performed risk factor analysis, which showed that advanced age, left main disease, and ischemic mitral regurgitation, left anterior descending endarterectomy were the predictors of MACE. And these results are consistent with our previously published research, in which we just built a nomogram to predict patient outcome. So the results of coronary endarterectomy in DCAD patients are acceptable. We still need more evidence. Unfortunately, we face many difficulties in performing high-quality studies in this population of patients. The reason is that the decision on CE is always made during the surgery, and we cannot preoperatively predict who needs an endarterectomy. In addition, an endarterectomy is not an optional option. We only need it when other surgical techniques fail. So the population is very limited. Another problem is the selection of control group. In the future work, we may need to make a shift of thinking. Since we cannot totally avoid endarterectomy, then we may consider how to improve the prognosis, such as improving the intraoperative techniques and postoperative secondary prevention. Our analysis has certain limitations. This is a retrospective analysis with limited sample size and follow-up from our limited follow-up from our single center. In addition, we were not able to compare the open and closed techniques at our center. So let's make a summary. Coronary endarterectomy with CABG can be performed safely with acceptable outcomes, but should be used cautiously, since it's a very technically demanding surgery. Risk factors for patient prognosis include advanced age, left main disease, mitral regurgitation, and left anterior descending endarterectomy. As coronary endarterectomy cannot be avoided, future studies might need to focus on how to improve the prognosis, and a clinical trial regarding the secondary prevention after coronary endarterectomy is ongoing at our center. Thank you.
Thank you very much, Dr. Timur Niazi. That was a beautiful presentation. Fuai has indeed much experience. Now it's my great pleasure to introduce Super Professor Niinami to present super skeletonized gastroeploic harvest.
Thank you, Teresa. Good afternoon. I'm going to talk about the skeletonization of the GEA, especially the super skeletonization. There are the couple of options to use the third arterial conduits. One is a radial artery, and another one is a GEA. And in the Western countries, I think the radial is the most popular conduit, and the GEA is not. Even in Japan, we don't use much the GEA, but a little bit more than the RA. One of the problem using the GEA is the prone to spasm. So there are some way to avoid the spasm, which is the pharmacological way, such as the papaverine or phosphodiesterase-3 inhibitors. Another way is a GEA skeletonization to denervate the nerve. This paper is published from the Japanese group, and then this is an experimental study using the human sample to determine whether removing the periarterial sympathetic nerve of the GA can reduce vasospasm or not using the skeletonization technique. This figure shows the left side is a non-skeletonized way, and then right side is a skeletonized way. And then this is a histochemical staining, and removing you can still see removing the nerve using the skeletonization fashion. I don't explain the detail, but what they conclude was removing the periarterial sympathetic nerves from human GA reduce the vasoconstriction induced by peripheral nerve stimulation. This reduction may contribute to the prevention of vasospasm, and it is recommended that GA should be harvested as a skeletonized fashion using the ultrasonic scalpel. So we aggressively use this kind of the device, harmonic scalpel. Actually, this device is still we can use it. Another type for ITA is currently not used in the rest of the world, except Japan. So the preoperative assessment of GA is very, very useful, and then And we can tell the size, length, and the quality. Sometimes you can have a very, very, very good one. Also, the angiogram show that you can plan how to use this conduit for the cabbage. So I'm going to show you how to harvest it. The incision is just extended 3-4 centimeters to the abdomen and open the peritoneum. And GA is much easier compared to harvest compared to the ITA because you can see it and it's very flat and easy to identify. And normally I just pass this elastic sutures around the GA and just between the artery and the vein using this scissors type harmonic scalpel. If you injure the vein, it bleeds a lot, so try not to injure the vein. But as you see, it's really easy to harvest it. So this is a regular way of the GA skeletonization. This is the proximal part. I normally use the maximum the strength of the harmonic scalpel. It takes on maybe 10 minutes to harvest this way. So, and then if you check the histology and then just a regular skeletonization, there still remain the nerves, which makes the spasm. So, what is a superskeletonization? Which is removing all these surrounding the tissue and then eliminate all the nerve. That is a superskeletonization. So what I do is just removing those tissues from the GA. Actually, this takes more time than taking the regular way of the skeletonization GA. It takes about 15 minutes to 20 minutes. It takes time, but we can remove all the nerve to avoid the spasm, which makes it the longer time patency, I think. And compared to the ITA, if you do this way for ITA, you may injure easily, but the GA is quite strong. It's more muscular, so you don't need to worry about too much about the injuring of the GA. And sometimes you can easily peel off this tissue. Once you take those tissues, and then you can tell that the arteries start expanding. So another example, almost the same, but this is actually the biggest GA I've ever had in my life. Sometimes you can have this kind of very, very big one, okay? But when you take down the GA using the harmonic, sometimes the GA start shrinking because of the spasm. I apply this the harmonic very close to the artery because I always do the superskeletonization, so I don't worry about some kind of some are injured, but I peel off all the surrounding tissue after the taking down. So this is the usual way. Then superskeletonize. Of course, sometimes you injure the branch, but you may need to use a 8 or 7 proline to fix it. But I never had a dissection, not like the mammary artery. And you can tell it starts expanding. And then after taking down, then I always close the omentum before administration of the heparin. Then I cut the end and check the fluid flow. And once you check the good free flow, and then transfer into the chest, making the hole into the diaphragm, just almost the center of the diaphragm, 1 centimeter hole. And then you can use anyway. I mean, this is a PDA LV branch sequential, but it's like a saphenous vein, so easy to do the sequential grafting. The diamond anastomosis, then the left ventricular branch. I tend to do the parallel side to side rather than end to side. And just clip and then chopped off. So I think the GEA is a great, elegant, and attractive conduit for cabbage. Thank you very much for your attention.
Oh, thank you very much. That is a beautiful conduit. It's like a beauty treatment for the GEA. Okay, now we're going to move on. Sorry, we're a little over time. Dr. Christopher Lau, and he's going to speak about how to do a quick and safe posterior pericardiectomy, cardiotomy, every case. Thank you.
Good afternoon. I'd like to thank the committee again for the opportunity to talk about this, how to do pericardiotomy in every case. Let's see. Okay, so what is the posterior pericardiotomy? I think most of us are familiar with this already, but it's an incision in the left posterior pericardium that allows drainage of any fluid within the pericardium into the left pleural space. We've shown that it reduces the incidence of postoperative atrial fibrillation in CABG, valve, and aneurysm cases, and the benefit was quite large and the risk was quite minimal. This is why we do it. So the incidence of post-op AFib in the pericardiotomy group in our trial was 17% compared to 32% in the group without pericardiotomy. And we also found that there was a significant decreased incidence of pericardial effusion on the follow-up echocardiography in patients who had the pericardiotomy. And what's the hardest part of doing a posterior pericardiotomy? It's actually remembering to do it, because it's not a usual part of our armamentarium, at least in the past. And so you have to pick a time to do it and do it at that time in every case. So this is one of our original videos on how we did the pericardiotomy. You can see that we're doing this with the heart beating. This is an on-pump CABG case. And initially when we did this, we did it with the cross clamp off in order to not add additional cross clamp time, but we quickly figured out that it was so quick and easy to do that we started just doing it on pump at the appropriate time. And when I was invited to do this talk, I had to then figure out how to make this quick, simple operation much more complicated so that I could fill my 10 minutes. So here are the thoughts that I came up with. These are some of the factors to consider. Whether you're doing your bypasses on pump or off pump, the timing is important, especially when you're doing it in off pump cases. Some of the reasons might be depending on how you set up your off pump exposure, you may need to have an intact pericardium in order to expose your lateral wall targets. And so in these cases, a good time to do it might be after you've done your lateral wall targets and are ready to drop the heart back down. And this is an example I found of that. So this is the exposure for the lateral wall, and you can see over here that you can see the left lateral pericardium quite well in order to do your pericardiotomy. If you're doing on-pump CABG, then your pericardiotomy can really be done at any time, and the timing is up to the surgeon's preference. And it can also depend a little bit on how you do your exposure setup, whether you have someone hold the heart or you have some sort of exposure system holding your heart for you, and also what order you do your targets in. We typically do it, again, after the lateral wall targets are done because the heart is already lifted and up, and that part of the pericardium is already exposed. This is an example where someone is holding the heart for us. So if someone's going to hold the heart for you, you can have them pick up and drop the heart at any time. And then at any part of the case, whether it's after your lateral targets or if you forget and you have to do it at the end, you can do that as well. And it's very quick and simple to make an incision in the pericardium here. In the next case, you can sort of see we have our retraction system here. We use these lap pads to hold the heart up so we don't depend on someone actually holding the heart. And you can see the anatomy pretty well. The phrenic nerve was over here. The left inferior pulmonary vein was over here. And we're going on the left posterior pericardium, vertical incision between the inferior pulmonary vein and the diaphragm. And since we've just finished all our lateral wall targets, the heart was already lifted up with the retraction system, so we take a few seconds to quickly do our pericardiotomy at this time. The next thing to consider is whether your pleura is opened or closed. We already saw earlier today that you can harvest your internal mammaries with the left pleura opened or closed. If the pleura is open during your ITA harvest, then the pericardium is actually very easy to grasp with forceps. You have folds and things that you can grasp easily, but it's quite difficult to grasp if your left pleura is not entered because of the negative pressure in the left chest. There are no folds to grasp. So if the pleura is closed, usually use cautery to score the area so you have something to hold on to. So this is an example of the left pleura is already opened, and so the pericardium has a lot of folds in it, and by moving it around with your suction or another forceps, you can have grasp the pericardium pretty easily. In this example, this is not actually a bypass case, but in this example, the pericardium is still closed, so it's very hard to pick it up with a forceps, so you definitely need long-tipped instruments, and if you score the pericardium, you can then pick up that little edge, and when you're doing this, you can see your phrenic artery, and you can see lung behind the pericardium, so if you see lung, you can know that it's a pretty safe area to make your incision, and then once you make a little score, you can pick that up with the forceps. The last thing to consider is whether you're going to put a drain. If your left chest is open or you have a left chest tube for any other reason, then pericardiotomy drain is not really necessary because your left pleural tube will drain the area well enough. But if there's no other pleural drain on the left side, then we usually put a drain through the pericardiotomy, which will help prevent pneumothorax and accumulation of fluid. And we usually prepare the drain before actually lifting a heart for the pericardiotomy. So in preparing the drain placement, we usually use a 19 French soft channel drain. And if you're going to use a small drain like this, when the heart fills, it can actually push your drain out. So you have to insert it at the right angle to prevent that from happening. And then here we've already performed our pericardiotomy, and so we put a drain through the opening. I usually lay it on the diaphragm surface between the lung and the diaphragm, and even though it's low and posterior like this, it seems very effective in preventing any pneumothorax, and it definitely drains the fluid very well. So some final thoughts on this. The posterior pericardiotomy is a quick and simple method to reduce the incidence of postoperative atrial fibrillation. We also have some unpublished data that you'll see in upcoming talks that it also reduces the incidence of early readmissions within the first 3 months. So there are a lot of benefits of the procedure that keep coming through as we follow the patients out. The technique can be modified depending on your specific setup and the order in which you do your distal targets. But if you're going to make the pericardiotomy, you have to take extra care to ensure that there's no bleeding from your distal anastomoses. The pericardiotomy can drain any bleeding or blood in the chest very effectively into the left chest. And if you don't look directly at your anastomoses, you can have a lot of bleeding into the left chest and not see any of it because it's all draining through the pericardiotomy. Thank you for your attention.
Here, hello. Thank you very much, Dr. Lau. That is very well presented. A technique that I don't know. Can I have an audience, hands up, who uses this technique? I guess I'm behind. Okay, maybe I should start. Okay, well, thank you all for this wonderful session, and I think we better pack it up because we're late.